Kia ora and welcome to our final 2025 Blood Cancer Patient Forum. It's great to have you with us today. Our topic is CAR T therapy in New Zealand, which is an exciting and important area of treatment. My name is Nikki Roy and I'm a Senior Support Services Coordinator here at Leukemia and Blood Cancer New Zealand, based in Wellington. I'm also joined by Dr. Philip George and Petra Minehan, who I will introduce to you in a moment. This session will be recorded and we'll have some time for questions at the end. If you have any, please feel free to post them throughout the presentation in the Q&A box on your screen, and we'll get through as many as time allows at the end. It is now my pleasure to introduce our guest speakers. Dr. Philip George is a consultant haematologist at Wellington Hospital. He undertook specialty haematology training in the University Hospitals of Leicester, UK, which he completed in August 2022. In 2018, he took time out of clinical training to carry out a clinical research fellowship in chimeric antigen receptor, or CAR, T-cell therapy at the Mulligan Institute of Medical Research in Wellington. During his 3-year fellowship, he worked extensively on setting up the ENABLE trial, a phase 1 anti-CD19 CAR T-cell trial for patients with relapsed and refractory B-cell non-Hodgkin lymphoma. He was awarded a Masters of Clinical Research with distinction at the Victoria University of Wellington in August 2020. He is now the principal investigator of the phase 2 ENABLE-2 CAR T-cell trial, alongside his duties as a consultant haematologist. Philip's specialist areas of interest as a haematologist are lymphoma, myeloma, and cellular therapies. Petra Minehan is a clinical trials research nurse working across oncology and haematology with 8 years of nursing experience. Since joining the Wellington Hospital Clinical Trials Unit in early 2024, Petra has been involved in the delivery of CAR T-cell therapy in Aotearoa, New Zealand. She supported the treatment of the final patients enrolled in the phase 1 CAR T-cell clinical trial and has now taken on the role of lead study coordinator for the phase 2 ENABLE trial. Petra takes a calm and compassionate approach to her work, helping patients and their whānau feel informed, supported, and empowered through their clinical trial experience. Thank you both so much for joining us today. Philip and Petra, over to you.
Thank you very much for the introduction, Nikki. It's good to be here. I'm really excited to do this talk. So we're just getting up the slideshow now, so just bear with us for 1 second. Hopefully we can see those slides on the screen.
Yes, we can. All good.
Great. Excellent. So we're going to talk to you today about CAR T-cell therapy, and in particular focusing on the ENABLE trials, which are the CAR T-cell trials that we've had in New Zealand. The first one being the ENABLE trial, which opened in 2019. So we're going to talk through, there we go. Okay, so you can see the objectives now on the screen?
Yes, we can. Thank you.
Great, thank you. So we're going to talk through just some basics about, how CAR T-cell therapy works. We're going to talk about what are the benefits of CAR T-cell therapy, what kind of conditions can it treat. Also talk about some of the common side effects and in particular how we manage those side effects. That includes patient education, how we manage as an outpatient, and some of the monitoring processes that we have in place to do that. We're going to talk a little bit about the experience we had for the phase 1 CAR T-cell trial called the ENABLE trial, and then a bit of an update on the phase 2 ENABLE-2 trial, which is currently open for recruitment in Wellington, but also in Auckland and Christchurch as well. And then we're going to touch on some of the potential for future CAR T-cell therapy in New Zealand as well. So you can see on the screen here that this is essentially the first person who was treated with CAR T-cell therapy back in 2010. She was treated for acute lymphoblastic leukemia. She was treated in the US, and she's actually in remission This is a picture of her 10 years later, after receiving CAR T-cell therapy. And she's in ongoing remission. So she was really the sort of poster child, if you like, for CAR T-cell therapy. That's in the very early days of that therapy, and it's really taken off dramatically as a worldwide treatment in B-cell cancers, particularly in B-cell non-Hodgkin lymphoma, and particularly the aggressive B-cell lymphomas, and also in acute lymphoblastic leukemia, although we're not treating for that indication in New Zealand. And I guess just to say that CAR T-cell therapy is really, in a way, it's a living drug, because we're actually infusing a patient's own T cells, which are modified, so part of their immune cells, back into them. And the idea is that those cells can then expand in the blood and actually target the cancer cells. So we're actually looking at a living drug, essentially. So it's really exciting type of therapy. We're going to talk you through that in more detail, essentially. Okay.
Cool. So this is just a wee bit of an overview of how CAR T cell works and is produced in our first phase is a leukapheresis phase. So this is where blood is drawn from the patient and white blood cells are separated, and the rest of the blood is returned through to the body. This product is then sent to a lab where it is purified. So the T cells are purified from the white blood cells and then reprogrammed. So the T cells are reprogrammed by introducing a genetic sequence through a lentiviral vector. So the T cells produce new surface receptors called CARs. These CAR T cells can now recognize and attach to specific marker proteins on the cancer cells, which signal their destruction. This is then expanded, so the CAR T cells are then expanded to create millions of copies. And before they are infused back into the patient, we give them what we call conditioning chemotherapy or lymphodepletion. And so the idea of this is to clear out any of the competing immune cells, especially T cells, which creates an environment where the CAR T cells can expand without competition. And then step 7 is to administer the CAR T cells, so they are infused back into the patient, and then we follow them up with monitoring for side effects.
Okay, so this is a diagram of a CAR T cell, essentially. So what you can see here, that a chimeric antigen receptor is really combining two different receptors from cells. So you're looking at combining B cells with the T cell receptor. So you can see, the arrow on here, that on the outside of the cell, which is where the arrow is at the moment, this is taken from an antibody which comes from a B cell, from the receptor of B cell, and this is actually attached onto the inside of the cell to a T cell receptor complex. So you've got the combined effect of a B cell receptor and a T cell receptor, and this occurs inside the T cell. So you're actually genetically modifying the T cell to express this receptor, which is a chimera or a fusion of the two different receptors. And what that does is it essentially targets your T cell against a marker on the tumor cell. So the receptor on the outside of the cell can actually recognize a marker on the tumor cells. And what we're looking at with lymphomas in particular is a marker called CD19. So you might hear the phrase anti-CD19 CAR T cells. What that means is that the T cell, which combines these receptors, is recognizing the CD19 marker on the tumor cells. And essentially, over time, they've developed different types or different generations of chimeric antigen receptors. And you can see that the first generation, a little bit more simple inside the cell, didn't have these extra domains, whereas the second generation has this extra domain here, which helps to stimulate the T cell to have more effect. And then you've got this third generation CAR T cell here. And actually, the product we're looking at in New Zealand is what's called a third generation CAR T cell product. The CAR T cell products which have been approved and licensed internationally, for example, in Australia, the US, in Europe, they're actually second-generation CAR T cells. And you can see these are the drugs, for example, Axicell, Lisacell are some of the most well-known commercial products. And we've now got CAR T cell products licensed in a whole host of different conditions, including myeloma, acute lymphoblastic leukemia, as well as lymphoma. In New Zealand, the ENABLE-2 trial is purely looking at patients who have B-cell lymphoma, in particular, large B-cell lymphoma. Excuse me. So this is essentially just a timeline looking at the different treatments that have become available. And you can see really since 2018, there has been a sort of explosion of new therapies that have been coming onto the scene in large B-cell lymphoma. You can see that the first FDA approval here was for Axicell, which is a second-generation CAR T-cell product. And since that time, there have been a whole host of new CAR T-cell products being approved in that time frame. Unfortunately, at the moment, we don't have any approved CAR T-cell products in New Zealand in a commercial setting. We're purely looking at a trial setting at the moment in New Zealand. So this, if you look at the top graph here, this is historical data looking at outcomes of patients with refractory, so very difficult to treat large B-cell lymphoma. And that's where the lymphoma has not responded or has relapsed after chemotherapy, essentially. And really what you can see is historically, unfortunately, this group of patients do quite badly in terms of the response to standard therapies, and the overall response rate to standard therapies, including chemotherapy, will be around 26%, with only a very small complete response rate. And unfortunately, these patients do have a poor median or average survival of just over 6 months. So we know that this area is an area of unmet need. And this is where the Zuma-1 trial, which looked at this product called Axicell, which is a second-generation CAR T-cell product. You can see here that the overall survival at 2 years with this trial and this CAR T-cell product was around 50%, and that's a very significant improvement when you compare it to the standard therapies that were available before CAR T-cell therapy. So we can see that there is definitely a significant improvement to conventional therapy. However, there is still significant scope to improve long-term response rates and survival, obviously, as well. So there's a lot of work to try and optimize CAR T-cell therapy and improve it in different ways. We can talk about some of that a bit later. So when we set up the ENABLE trial in Wellington, this was really a joint venture. The Malaghan Institute was the sponsor of the trial and really set up also the manufacturing of the CAR T cells to actually make the CAR T cells. And the scientists at the Malaghan put in a huge effort to get this process sort of MedSafe approved and go through all the regulatory processes to get it up and running. So the CAR T cells were manufactured at the Malaghan Institute, which is a scientific or immunology research institute in Wellington. It is a charity, and it focuses on immunology research. And for the trial, we were treating patients in Wellington Hospital. We were actually treating patients from throughout New Zealand. So we accepted referrals from all across New Zealand, and we had great support from Leukemia, Blood and Cancer New Zealand in order to help with patient funding for transport and accommodation, which really improved the equity of access to the trial, which was fantastic. And obviously, we had other regulatory agencies nearby, such as MedSafe. So the Malaghan Institute, just a little bit of background, it was established in 1966, thanks to a major gift from Tip Top founder Len Malaghan. It is Wellington-based, but it really does have an international impact, collaborators from all over the world. It has a real impact on a global scene. It is an independent charity funded by the community and the corporate sector as well. And also looking at funding from government grants and other grants as well. But it's a really fantastic institute that's leading the way in immunology research. So this was the protocol paper for the phase 1 ENABLE trial. This opened to recruitment in 2019 and finished recruitment in end of 2023. And this was a sort of early phase trial. It's really a safety trial because this was the first time this product had been used to treat patients for real. So this was looking at patients who unfortunately didn't have any other standard of care treatments. And we performed what's called a dose escalation trial, where we started at a very low dose. And we treated 3 patients at the lowest dose and then escalated the dose up according to being safe to do so. And there was strict criteria about how we did that. And we had a data safety monitoring committee to oversee the safe escalation of the doses. And in the end, we actually treated 30 patients in total in the phase 1 trial. And some of those were on a dose expansion trial where we found the right dose that we wanted to use. And we treated another sort of 9 or so patients at that specific dose to a total of 30 patients. So I'm going to pass over to Petra for this bit.
So I just want to talk through some common side effects of CAR T cell therapy. So in phase 2, the phase 2 trial, this is actually being given as an outpatient treatment, which allows patients to either go home or stay within 20 minutes of the hospital for the first 14 days. So as part of that, education being provided to the patient themselves and to their support person becomes really important. Our 2 main side effects are cytokine release syndrome and immune effector cell associated neurotoxicity syndrome. So CRS is a systemic inflammatory response that occurs when the activated CAR T cells release large amounts of chemical messages called cytokines. CRS can cause flu-like symptoms, including high fever, muscle aches, fatigue, and low blood pressure. And in severe cases, it can affect major organs and require intensive care. ICANS refers to neurological problems that can arise from CAR T cell therapy, and symptoms can vary widely, but may include confusion, difficulty speaking, headaches, tremors, and in rare cases, seizures. So CRS onset is usually 1 to 6 days post CAR T cells. 95% of CRS events occur within 14 days, but occasionally can occur later. Fever is the first sign, and so therefore it's important to consider febrile neutropenia, as most of these patients will be neutropenic also, and they are given a neutropenia card. Temperatures above 39 degrees and flu-like symptoms are common, and other key features include low blood pressure, low oxygen levels, and increased heart rate. For ICANS, a typical onset is seen at about 5 to 10 days post-CAR T. The mechanism for ICANS is not fully understood. It can occur concurrently with CRS or independently. There's systemic inflammation and high levels of cytokines may disrupt the blood-brain barrier, and this can lead to an inflammatory cascade within the central nervous system, which can lead to altered neurological function and cerebral swelling in severe cases. So how do we assess for CRS and ICANS? So from days 0 to 14, as I said before, we ask that the patient and their support person stay within 20 minutes of the treating hospital. Temperature monitoring is done every 8 hours. CRS assessments are done daily and ICANS are twice daily. So usually the patient and their support person will come into the Wellington Blood and Cancer Day ward in the mornings for assessments, and on the weekends they'll come up to our inpatient ward for those assessments. The support person is trained to complete the afternoon and evening assessments and to also monitor temperature. If the patient is well on day 14, they usually discharge back to their home DHB if they're from outside of Wellington. And from days 15 to 28, the temperature is monitored daily. The ICANS assessments are done by the support person, and then they come back on day 28 for CRS and ICANS assessments with the team. So this is just a bit of a look of what sort of resources we use within the hospital. So this was developed for the nursing team, and this is our CRS clinical assessments. As you can see, we monitor temperature, blood pressure, oxygen levels, and heart rate. And this is the sheets that we use for assessing for ICANS. So we ask the patient orientation questions. We ask them to follow commands, 1 or 2 steps. We ask them to name objects. We also do get a handwriting sample from them and compare it to a baseline handwriting sample. And we ask them to count backwards from 110. This is why we assess the handwriting. So often in ICANS, handwriting will often be the first thing that will change. And as you can see, there is an example there on the screen of a patient who did develop ICANS and what their writing samples look like at the time. This is some of the resources that we've developed for the support person. So these are the assessment sheets that they use to do the afternoon assessments. So what's the treatment for CRS and ICANS? So for CRS, it depends on the grade. Most often we use supportive cares. So for example, if they have low blood pressure, then we use vasopressors to increase blood pressure, or low oxygen levels, then we use oxygen supplementation. We also make sure we have a drug called tocilizumab on site and plus or minus corticosteroids. For ICANS, this also depends on the grade. We can use corticosteroids plus or minus tocilizumab and anti-epileptic prophylaxis. So tocilizumab works by blocking a protein called IL-6, which is involved in the inflammation process, which helps to reduce symptoms and protect the patient's body from severe damage. Other side effects can include low blood cell counts, so the lymphodepleting chemo and the therapy itself can lead to a reduction in white blood cells, red blood cells, and platelets, which increases the risk of infection, fatigue, and bleeding. Low B cell count, so the CAR T cells, by targeting CD19, also destroy healthy B cells, which can lead to a weakened immune system and a higher risk of infection, which may require intravenous immunoglobulin supplementation. Or tumor lysis syndrome, when a large number of cancer cells are rapidly destroyed, they can release their contents into the bloodstream, which can cause issues with the kidneys. So how have we prepared for toxicity management in New Zealand on the ENABLE trials? So we developed a multidisciplinary CAR-Tox group, which included teams from hematology, neurology, immunology, and intensive care and nursing. We created the development of agreed CRS and ICANS recognition treatment pathways. We created and developed training and competency assessments for staff. We have a process for ensuring we have on-site tocilizumab. There's a 24-hour number to the ENABLE trial investigator. The patients receive emergency cards, and there's toxicity guidelines on the hospital intranet as resources. This is just a quick look at some of the resources that we've created for clinical staff within the hospitals, the grading and management of CRS, and for ICANS also.
So this is just an overview really of the outcomes from the phase 1 ENABLE trial. So you can see that there were 30 patients treated. We treated 5 different dose levels in order to try and find the right dose, and we settled on the dose of 1 million CAR T cells per kilogram, which is actually about 50% of the dose that is used for some of the products. For example, Axicell, one of the second generation products, uses approximately 2 million CAR T cells per kilogram. And then we treated approximately 9 patients at the recommended phase 2 dose as a dose expansion. So we looking at that particular dose that we had identified. And in terms of kind of outcomes, so we were particularly interested in looking at the toxicities of cytokine release syndrome and the neurotoxicity called ICANS, which stands for immune effector cell neurotoxicity syndrome, which Petra has talked through just now. And basically, when we were looking at those toxicities, we found that about just over half of patients did develop cytokine release syndrome, but actually all of those cases were mild. We call it grade 1 or 2. So no patients actually required to go to intensive care. And that we actually found was quite a low toxicity rate when you compare the toxicity to some of the other second generation CAR T cell products which are approved. And in particular, we found that the ICANS rate, the neurotoxicity, was particularly low. We only actually had one patient who was recorded to have neurotoxicity. And certainly, when you compare that to the data from some of the approved CAR T-cell products, that does seem to be a lower rate. Having said that, this is, still a very early phase trial. This is very preliminary data. So it's very hard to draw too many conclusions, but there's certainly enough reason to want to go on to do a phase 2 trial. When we looked at the complete remission rates, the rate was just over 52%, so just over half of patients did go into a complete remission after 3 months of treatment, which again is perhaps broadly comparable to some of the other CAR T-cell products. But again, we are talking quite small numbers, so it is very hard to apply that with too much confidence at this stage. So just for an example, this is a patient case from the phase 1 trial, a patient who was treated at that top dose level 5, so 1 million CAR T-cells per kilogram. This is a lady who had quite refractory diffuse large B-cell lymphoma. She'd had multiple prior chemotherapy treatments, including R-CHOP, R-DHAC, a more intensive salvage chemotherapy. She'd also had an autologous stem cell transplant as well, and had relapsed after that. And you can see this is a picture on the left here before the CAR T cells were given, day -4. And these lesions on the thigh were actually the lymphoma lesions. And you can see on the PET scan on the left-hand side of the screen, on the leg here, this represents the lymphoma lesions you can see here. And these are some pictures that were taken after the course of CAR T cells. So this is at day +3. And then this is at 10 days after treatment. And you can see that the skin lesions are receding following the treatment. And this was the PET scan taken at 3 months post-CAR T-cell treatment. And you can see that all of the lymphoma lesions that were lighting up on the PET scan before treatment have actually disappeared on that scan, indicating a complete remission. Just to say that the uptake you can see in the brain, in the bladder here, these are normal sites of uptake that you would see in everyone. So I guess just to summarize the outcome from the phase 1 trial, on the right-hand side here, you've got the phase 1 trial. And this is just compared to the ZUMA-1 trial, which is a phase 2 trial for the axi-cell product. And obviously, it is difficult to compare between trials because the way the trial is conducted is different and the groups of patients can be different as well. But just to get a feel for how this product may have compared to another product, you can see that the rates of the toxicities do seem to be lower, with the rates of CRS and ICANS being lower compared to the axi-cell product here. Broadly comparable response rates, noting that this is still a very early preliminary result, but useful to compare. And you can see here that this was a comment from Professor Carl June, who is really sort of renowned as one of the pioneers, really, of CAR T cell therapy from University of Pennsylvania in the US. And he's now involved in the company which are manufacturing the CAR T cells for the phase 2 trial, a company called Biora. And he commented that Dr. Wynkow and team have shown efficacy that is on par with commercial CAR T cells, but the safety signal appears superior. This lays the foundation for outpatient delivery and management and expanding indications for their CAR T cell program. So obviously, really good endorsement to get. So how are we sort of trying to improve CAR T cells and the sort of process going forward? So again, the team at the Malaghan Institute and now at Biora, who is the biotech company who are now manufacturing the CAR T cells, they've really improved and streamlined the process for manufacturing CAR T cells. So when we first started manufacturing CAR T cells, the scientists would be a very manual process would be used to manufacture the CAR T cells, very heavy on operator hours, so over 42 operator hours for each product. And it's very sort of heavily involved, complex steps to perform the manufacture. There's been some real sort of changes, innovations to improve that. And for example, we're using these machines called cocoons now, which are basically semi-automated machines to carry out a lot of the manufacturing process. And that really cuts down the operator hours required and reduces I suppose, some of the potential for human error in the manufacturing process, and really trying to optimize and streamline the process to make it more efficient. So hopefully making the product time less and more efficient going forward. So the ENABLE-2 trial, so this is a phase 2 trial, which is really the primary outcome measure for this trial is to look at the complete response rate of the treatment at 3 months. So we measure that by a PET scan at 3 months after treatment, and we compare that to the PET scan taken immediately before treatment. This is a trial that's using outpatient management. So we give patients their CAR T cells usually on our day units, and then we try and manage patients as much as possible through our outpatient setting. So regular reviews on our day ward, pretty much daily for the first 10 days, and very close monitoring of toxicities. And then we do a very low threshold to admit patients to hospital if they're unwell, any sign of infection or other toxicity such as cytokine release syndrome. And this is a national trial. So we have now open sites in Auckland as well as Christchurch, and all 3 sites are now treating patients, and we coordinate our referrals between all 3 sites. We have a number of different companies involved in the trial. So the Malaghan Institute is the sponsor, Biora, the manufacturer for the CAR T cells, a company called Novatech are the clinical trials research organization monitoring the trial. We have endorsement from the ALLG, which is the Australasian Leukemia Lymphoma Group. We also have travel support from Leukemia Blood and Cancer New Zealand, which is fantastic. And tocilizumab, which is used to treat cytokine release syndrome, is funded by Pharmac. I think Petra's going to.
So this is just a wee bit of an overview of the schema of how ENABLE-2 works in New Zealand. So the aim of the phase 2 trial is to treat 60 patients in total. And we start off with a consenting visit. So the patient comes to site, either Wellington, Christchurch or Auckland, and they are consented to the trial. They undergo screening procedures, which includes a PET scan, and the screening procedures let us know whether the patient meets the inclusion and or exclusion criteria. If they do meet that, then they are enrolled into the trial. And from enrollment, we take them through to cell harvest or apheresis. Once this is done, those T cells are then sent off to the lab, and the CAR T cells are produced. Now, there's generally a 4 to 5 week time period in between cell harvest and administration of CAR T. So we usually provide some sort of bridging therapy in here. The aim of the bridging therapy is not to cure the lymphoma. The aim is to keep it almost in holding until we can treat. The CAR T cells are then given on day 0. Oh, sorry, production. They have a pre-lymphodepletion PET. And then they have the lymphodepleting chemo. So from day -5 to day -3, they receive a low-dose chemotherapy, and then that brings us through to day 0, which is the day of our CAR T cell administration. As Phil said, we keep them in close monitoring, although as an outpatient for the first period here. Up to 14 days, they need to stay within 20 minutes of the treating site. After day 14, if the patient is well, then they can discharge back to their home DHB if that's outside of Wellington, with regular contact points through to day 28 when they return to site. They have a PET scan at day 28, which is then reviewed. They have a follow-up at month 2, and then month 3 is our assessment point. So they have another PET scan then, and then we review that. There's another PET scan at month 6, and we continue to follow the patients up through month 9, 12, 18, and 24, with these later scans being CTs, and then the patients move into long-term follow-up. So currently we are open to recruitment in Wellington, Auckland, and Christchurch. A lot of work has been done by those teams in Auckland and Christchurch to get up and running. It's been fantastic having them on board. And currently we have treated 17 patients across those 3 sites. We meet fortnightly to discuss referrals, plans for leukapheresis and treatment plans. And we've really seen this as an opportunity to build a national CAR T-cell treating network within New Zealand.
So just very sort of briefly going to touch on what could be, potential future research opportunities in New Zealand for CAR T cells. And this is very sort of preliminary ideas, and nothing is yet set in stone at all. But there's, concepts would be in the future potentially be able to treat other indications with CAR T cell therapy. And that could involve, using CD19 directed CAR T cells for other indications such as follicular lymphoma, maybe even for CLL potentially, or using CAR T cells that target other markers. So, for example, we know that BCMA is a marker that's very much used for myeloma, and there are other CAR T cell products which are effective in the myeloma space. So there's the potential that, we could use this sort of protocol potentially to move into treating patients with myeloma, or potentially even solid cancers as well, although that may be a bit further away. So there's lots of opportunities that other more early phase CAR T cell trials could come into fruition further down the track, but there is still obviously quite a lot of work to go before getting to that stage. And at the moment, the team is really very focused on the ENABLE-2 trial, the phase 2 trial we're working on at the moment, which is in full recruitment, obviously, throughout the country. So I think in conclusion, immunotherapies such as CAR T cell therapy are really shifting the treatment paradigm for B-cell cancers, in particular B-cell non-Hodgkin lymphoma. Unfortunately, at the moment, the access to these therapies is limited within New Zealand. Really, we're limited to clinical trial access for CAR T cell therapy and other immune therapies such as bispecific antibodies, for example, as well. But globally, the trend is very much shifting to using these treatments earlier on in the treatment of B-cell lymphomas. And we know that there are patients who have high-risk disease where chemotherapy is often less effective, where these newer immunotherapies can be very effective. And there are trials now bringing forward these treatments to earlier stages of treatment, which is really what we've done as well with ENABLE-2, because we are treating patients a little bit earlier on in their treatment in comparison to the phase 1 trial, which was very much patients at a last line of treatment, really. So very exciting to have the ENABLE-2 trial open to recruitment in New Zealand, with recruitment ongoing. I suppose some of the benefits with CAR T cell therapy to consider would be that this does represent potentially a one-off therapy. It is quite an involved process that does require a lot of logistical organization to collect the cells, go perform the apheresis, undergo that manufacture, then bridging therapy for the patients before they have the lymphodepleting therapy and then the CAR T cells. But potentially that is then a one-off infusion, and that's obviously advantageous in terms of not needing ongoing treatment potentially. Given the low toxicity rates that we've seen to date, particularly on the phase 1 trial, this treatment is suitable for outpatient delivery, which again is a significant benefit. And one of the CAR T cell fellows, Dr. Robbie Fife, performed a qualitative trial or qualitative research project, which basically looked at patient experiences having CAR T cell therapy on the ENABLE trial. And one of the feedbacks was that patients were kind of bored in hospital and found it quite difficult being in hospital for a couple of weeks. And that's one of the reasons why we sort of pivoted to outpatient delivery for phase 2. And we think that's a really good way, if we can, to treat patients, trying to keep people out of hospital where possible and where safe to do so, obviously. So I think that's some of the key points, really. Got a huge number of acknowledgements. It's a really multidisciplinary, huge team effort for the trial and for the Enable2 program. I guess in particular, just to say a big shout out to Professor Robert Winecove, who is the overall sort of lead for the whole project and was the principal investigator for the phase 1 trial. He's really sort of driven the whole program. There's a huge number of scientists and clinicians at the Malaghan Institute and now at Biora as well, who are really work extremely hard to deliver the program and to actually research and manufacture the CAR T cells. A number of people in the hospital and other organisations as well. And also, obviously, Leukemia Blood and Cancer New Zealand is a great support to the programme for patients. So I think that brings us to the end of the talk. So I'm very happy to answer any questions that you may have.
Brilliant. Thanks so much, Dr. George and Petra. That was a fantastic presentation, and we do have some questions come through here. First of all, just to clarify, diffuse large B-cell lymphoma is usually quite well treated by chemotherapy, and this is just an option for those who it doesn't work. Do you see this as one day being a treatment from the start for diffuse large B-cell lymphomas?
Yeah, that's a really good question, actually. And I mean, you're right that there is a good proportion of patients with diffuse large B-cell lymphoma that can be cured with chemoimmunotherapy, such as R-CHOP. And certainly those patients do very well with that treatment. As time goes on, we know there are more and more detail about the type of lymphoma that may not respond as well. And there's increasing research done on the sort of some of the genetic changes in the lymphoma or other molecular changes which may put it into a poorer prognostic group. And I think over time we may see that CAR T cell therapy may be directed earlier on, particularly in those very high risk groups. You know, there's one of the recent trials published was a trial that looked at comparing CAR T cell therapy to an autologous stem cell transplant. And that was in patients who have had one line of therapy before. And we saw that in those patients that had sort of early relapse of their lymphoma after frontline treatment, we saw that CAR T cells were superior to salvage chemotherapy and an autologous stem cell transplant in those higher risk patients. And so that's now been rolled out in some parts of the world as a second line treatment. I think as time goes on, there are trials bringing it even further forward, but I think particularly targeting what we think are the higher risk groups. And that's something that we're learning about as time goes on, as we get more data through about the molecular profile of some of these lymphomas. But I think chemotherapy still will have a very good place for a number of patients, because we know that, as you say, it can be curative for a proportion of patients, and that's not going to change, I think, as well.
Brilliant, thank you. Just as I read out the next question, Petra, if you don't mind, would you be able to stop sharing the screen? Just makes it easier for them to see us in a larger version. Brilliant, thank you. So the next question here is, how do you access the recruitment, and is there any age limit?
Yes, good question as well. So I would say that to access the treatment, really the best way is to speak to your treating hematologist or oncologist, because all of the clinicians around the country have access to the referral networks to refer patients for consideration of this treatment. So really, very important to speak to your treating clinician to advise whether you may be eligible potentially, and then to go from there. In terms of upper age limits, there is an upper age limit of 75 on this trial. So patients up to the age of 75 could potentially be eligible.
Brilliant, thank you. Are there plans to apply for this to be funded in New Zealand, or are there more trials that need to happen first?
Yeah, so one of the purposes of the trial is one of the goals, I guess, is to aim for registration as a commercial product within New Zealand, Australia potentially as well. So the manufacturers Biora, who have the I think the intellectual property of the product, are making inquiries and making inquiries with Pharmac and with MedSafe about the potential for funding in the future. Obviously, in order to be funded, you would have to have results from the phase 2 trial as a minimum, I think. So that's still some way away, but certainly the goal is to become a funded standard of care treatment in New Zealand. And I know that the Malagan Biora are putting a lot of work into planning for that in the future, and certainly we hope there could be significant advantages for this type of treatment in New Zealand, being manufactured locally, not having to import products from overseas, which does take the cost down quite a lot. But obviously, we do need to have further results and outcomes from the phase 2 trial before being able to progress that more formally, I think.
Nice, thank you. And just looking at it from a perspective with multiple myeloma, any idea when you think, that sort of capability might be available in New Zealand?
I'm afraid I don't actually. I think it certainly as a concept it is being looked at. I don't think at the moment there are any specific timelines that I can say for that. I think we all certainly would be supportive in the hematology community for CAR T cell trials in myeloma in that space, because it would be potentially a big area of unmet need, as you say. But at the moment, I can't give any indication of when that may be, actually, I'm afraid.
Thank you. Why was follicular lymphoma included in phase 1 but not in phase 2 trial?
So again, I believe that comes down to the prospect of being able to get the product funded in a New Zealand environment and approved. Really, in order to get a product to the market, it needs to be quite a defined indication. So if you look at all of the trials really for Axicell, for example, that each trial sort of included one group of lymphoma patients, so either a large B-cell lymphoma group or follicular lymphoma, for example. So I think the team designing the trial had to sort of go for one indication as a target to get that one to market, basically, is the goal. But certainly follicular lymphoma could well be a disease group looked at in future trials, because as you say, it was included in phase 1, which had a broader scope. So potentially in the future, there could be further trials with follicular lymphoma for this product, potentially. Again, they're not currently in the pipeline right now, but that's certainly a possible concept for the future, which would be really interesting, I think.
And if someone had a follicular lymphoma and then developed an aggressive B-cell lymphoma and was able to have CAR T, would that potentially cure both, or it would only affect the B-cell part at that stage?
Yeah, that's a good question. So we do treat patients that have a background of follicular lymphoma where the lymphoma has transformed to an aggressive B-cell lymphoma. I think I don't know the definite answer to that. I think we would perhaps hope that there is a chance that the follicular lymphoma could be cured, but by no means we don't know that. I think it would depend on the disease itself, the persistence of the CAR T cells as well. So there are probably different factors that play in there. But it's a good question, which is probably still not fully answered, I don't think.
No, thank you very much. We're getting through them here. Here's one. Can you speak to the July 25th press conference or press release from Auckland Uni, which implied CAR T cell therapy is not far away from being rolled out as standard of care across blood cancers? Are you collaborating? Is their trial likely to be second generation or third generation?
I don't know the specifics on that, I've got to say. I believe there is some collaboration with in the research capacity with, for example, the Malaghan Institute and Auckland University, but I'm afraid I don't know the specifics on that. I'm not sure if that's referring to the CAR T-cell product that's made through the Biora, or is that referring to a different product? I'm not sure. So I don't have any specific insight into that, actually.
Thank you. Great presentation, and thank you for all the work you're doing. Not really a question, but I guess this has helped clarify for me that this therapy would not be applicable for my condition, which is a T-cell large granular lymphocyte lymphoma. But thank you again. So I'm just presuming that is the case. And another question asking about whether it would be helpful for people with PVA JAK2 positive.
I don't think so, is my honest answer. I think I'm not aware of CAR T cells being used for that condition. There are expanding conditions, being used for CAR T cells are being used for. I think one of the key things is that you need to find a marker on the tumor cells which can be targeted, which you can manage the sort of what we call it on-site but off-tumor target. So, for example, in B-cell lymphomas, as well as targeting the B-cell cancers, the CAR T cells do target the normal B cells, and that can deplete the normal B cells. But actually, if patients have low normal B cells, one of the main complications of that is their immunoglobulins, the antibody levels can be really low, but we can replace immunoglobulins through the blood service, through a blood product given every month, and which we do that in some patients, whereas some cancers, the off tumor targets can be harder to manage. So yeah, so I'm not aware of that being used in JAK2 positive polycythemia vera, but there are expanding indications throughout the world being, that CAR T cells are being applied to. So it is really an exciting area in terms of worldwide research going on in it.
This is an interesting concept. Can other people's T cells be used in CAR T therapy? I'm presuming not.
Well, they can actually. So they can. The problem with that, it's kind of going into the realms of allogeneic stem cell transplant. So one of the problems that you would have potentially would be things like graft versus host disease, where the donor T cells could recognize the host as foreign and therefore could attack the body. So, for example, graft versus host disease of the skin or the gut could be where the donor T cells then target the host's skin or gut. So that could be a complicating factor. There have been trials looking at allogeneic or T cells from other donors. But I think because of some of those issues with either rejection or graft versus host disease, they haven't come into as much favor and haven't had as successful results as patients' own T cells being used. And I suppose that's one of the reasons for potentially bringing this sort of therapy forward, is that if patients have had less treatment beforehand, potentially their T cell fitness might be greater, so that the chances of having more effective T cells could be higher. So I think that's one of the advantages of bringing the treatment a bit further or a bit higher up and earlier on in the treatment for this condition.
Thank you very much. We've just got time for a couple more questions here. Are you able to share the complete response rate so far in the phase 2 trial?
Unfortunately not, and I don't have access to that at my fingertips, actually, because it's all managed through a sort of a separate organization that monitor the trial and collate all of that information. Bearing in mind that we have patients being treated in Auckland and Christchurch as well, and we're sort of based in the Wellington site. We have seen patients so far treated that have had a complete response, definitely. Unfortunately, not everyone gets a complete response as well. But I don't have data to our hands at the moment that we can give, really, I'm afraid.
And just the last one we can fit in here, how long did it take from the preclinical initiation to phase 1 for Enable? I presume that's between the two, is it?
So you mean going from preclinical concept of phase 1 to opening the Enable phase 1 trial?
I think so.
So I think you'll be looking at least sort of 3 years. I mean, certainly 2 to 3 years. There was a lot of work, preparatory work, to get the product manufactured and to make sure that it met a very strict regulatory process from MedSafe, from other organisations as well. So there was a lot of work that went in to that process as well. So it was certainly at least 2 years, I would say, to get to that space, really. And it was very exciting when it did open. It was really exciting to actually start using that treatment, and it was obviously the first time this treatment had been used in New Zealand. So that was a really exciting moment, I think, to get to that stage.
Absolutely, and I think we're coming to the end of the time we have, and that's a good thing to finish on the excitement of having this. And we're very grateful, Dr. George and Petra, to you both today for sharing all your knowledge and your expertise in this exciting field, and of course everyone that's been behind this to establish this capacity in New Zealand. And for the two of you today, we just again thank you for joining us. We really appreciate the hard work, dedication and compassion that you bring to your roles and to patients, and the collaboration that we share together. We're very grateful to you. And today's webinar was the last in our 2025 Healthcare Compass series. We will send an email with a link to all our recordings in the next few weeks for those who have missed them or who would like to watch again. And for our listeners today, we are sorry for those that we didn't get round to answering. We had lots of questions coming in there, but we will certainly try to get back to you about that. And we will send you out a feedback survey, which would be really grateful if you could complete, as this helps guide and shape our future patient forums. And once again, thank you very much to our speakers today, Dr. Philip George and Petra Minehan. We're really grateful for you giving us your time, and to all our viewers for joining us. We wish you a very good afternoon.
Thank you.
Thanks.